our next speaker, Dr. Ashish, who's going to share his experience with virtual reality simulator for cataract surgical training.
Good afternoon, everyone. At the outset, I'd like to thank Dr. Rohit Shetty and APAO AIOC committee for having me here and talking on this. Just trying to change gears, we've spoken about corneal scars and some corneal implants. This is something different. We are talking about virtual reality simulators for cataract surgical training. How does it enhance your surgical skills? Let's talk about the traditional training where most of the residents are trained on wet lab and whether it's porcine eyes or goat eyes. The tissue is different. There is insufficient surgical training. Apart from that, there is fewer than that hands-on experience. The teaching is not standardized, and some of us do have a longer learning curve. And there is a risk to the patient if the trainees are not adequately treated. To top to that, it was also the impact of COVID-19, especially in countries like India, where it was impacted. Training opportunities were less. This thereby increased risk to the patients because the trainee was operating after a much longer time with less experience in wet labs because of less availability of tissues. This in turn led to lesser confident surgeons, and when there are lesser confident surgeons, the increasing backlog, especially in developing countries like ours, was increasing. So how does simulation or simulation-based training bridge this gap when there is a more backlog, we need to train more people within a speculated time frame? We all know that simulation models, whether they're augmented reality or virtual reality, have been shown to reduce complications in most of the specialties, more so in ophthalmology over this decade, where it has improved a lot. Video-based training modalities have been accepted in recent years, and they are also as effective, but though not very effective as compared to the virtual reality or the augmented reality platforms. In addition, latest developments where the simulators have improved, there are haptics which give real life-like sensations. When you touch the tissue, it feels exactly like the conjunctiva or sclera. It feels exactly like you're dissecting a tunnel. So that's where the haptic feedback system comes into picture, augmented by instructors who help you know how to take this simulation-based training. So there are many simulators. I'm in particular talking about the Help Me See simulator, which is the extremely high fidelity 3D virtual reality simulator, which brings what it brings to the table is it gives you a real life-like feedback. When I say that, there are handpieces wherein you can select any instrument that you like, select any step in any surgery that you want, whether it's phacoemulsification or SICS or even complications management like anterior vitrectomy. So each handpiece you will be able to select the instrument that you like, whether it's 23 gauge or 25 gauge trocar insertion for anterior vitrectomy and things like that. There is a side screen which helps you know which step you are doing, and you can do it multiple times, maybe 50, 60 times a day in a training environment. So the dictum here is practice until you cannot do it wrong. This is possible only because of the feedback by the haptics, which you just saw in the previous slide, which gives you the simulation intuition feeling, and it has these advantages that it is superior to the training in the goat's eye because the issue of availability is there, which is different. There is a difference in feel of the tissue every time you use a different tissue in the wet lab. You can do repeated practice. As I said, you can do almost 80, 100 times in a day a capsular access, and you can't get it wrong, which is augmented by standardized stitching. But most importantly, there is no risk to any human tissue that is used during the surgical process. So it's completely augmented reality. The students learn better handling of tissues even before they do their first surgery in the OR. So that's what simulation-based training brings to the table. The flagship training that is going on right now, which we are a part of, is the SICS model, which has been developed long back, and it is taught worldwide. Whether you want to do a tunnel dissection, there are training tools and guidelines which tell you exactly in what depth of the tissue you are. If there is a complication, you can go back and redo it. So in each training environment, each of these steps are done multiple times so that you know exactly where you are in your training methodology. In addition to that, there are self-study materials, instructors, dry lab activities, and sessions like debrief sessions which help the trainee understand where they are in their journey of simulation-based training. In addition to SICS, we also have courses like pars plana vitrectomy, anterior vitrectomy, PCR management, and suturing, and phacoemulsification. So for this session, we thought we'll portray what we have on the phacoemulsification simulation-based training platform. Right from beginning the step of paracentesis to visco implantation to making a rexis, whether you're using a cystitome or a utrata, the simulator supports that. The guidelines or the images that you see are available on demand. So as you keep going ahead, you can take off these guidelines and continue the surgery like you do in a real life environment. It will also show you premature entry. It will also show damage to the cornea or the endothelium or even zonular dialysis. So this is what simulator brings to the table. Now this has been possible because of the efforts of a team of subject matter experts who actually sit down and tell what should cause this complication, what should cause this amount of zonular breakage. It's an iterative process, and because of this iterative process, the simulation-based platform gets enhanced every time. So right from hydrodissection to the steps like phacoemulsification, getting the trench in the nucleotomy at what dissection depth you are, seeing the foot pedal or the guidelines that you see is going to help. It is already helping students worldwide to know exactly what step should be done to get the depth of dissection right, to get the plane of dissection right, and even to have the separation correctly. So that's where this haptic feedback simulation-based training brings to the table. Now, when we say that, we also say that this is validated. Recent publication, which came in Scientific Reports in October 24, says that yes, this phacoemulsification module on this system is actually validated, and it helps trainee gain better experience and can be replicated worldwide across systems to have the same amount of training worldwide. So the phacoemulsification training that is present on the Help Me See system is actually having a validation effect. How effective we are, we actually did a randomized study where we divided trainees into two groups. One underwent simulation-based training, followed by mentored live surgical training transition. The other did traditional wet lab, and we had these trainees from institutes like LV Prasad, Arvind, Mahatma Eye Hospital, and then we compared the results, and to our knowledge, we saw that the group that did simulation-based training had at least 40% less complications, reduced learning curve, and higher confidence when they went into the OR to do the first live surgery. So yes, it is effective. Yes, the system is validated. Also, if you look at what are the virtual reality platform simulations, what are they doing? So all comparatively, there is another article that was shared that patient safety assessment in OR should be the prime criteria in choosing any virtual reality simulation-based training platform, and this is where the Help Me See simulator also scored well. So in addition to training residents, it is also going to be useful for people who want to enhance their surgical skills when they want to learn something new. And that's where we also had a suture simulator where passing the suture through a correct depth, tying the knot, burying the suture, cutting it, and all that is also possible. And this has also been recently presented at a meeting at AAO. So the take-home message, what I would like to share from our experience is that simulation-based training enhances skills and reduces complications. This in turn gives better outcomes to the patient. You can do more surgeries because the surgical time and the table time of the trainee and the attendee is reduced. It has been incorporated rightfully, and this is coming from places like Arvind, LV Prasad, Shankara, where they have the simulator going, which is incorporated into the residency training programs. So this definitely is a game changer, which everybody wants. At the end, should lead to a happy surgeon, happy trainer, and happy patient outcome. I thank you for your attention.
Thank you, Dr. Ashish. Would you say there's a learning curve in using the simulator itself, and what do you think is the minimum duration, because everyone doesn't learn at the same pace, so yes, what would be the minimum duration they have to use the simulator?
There is a learning curve, you're right, especially to getting used to the simulator, but that learning curve from anybody would be around 15-20 minutes to get used to the environment of the simulator. Having said that, yes, this learning curve is also incorporated into the training program, so that the stages that you go into the training program are met with. So yes, learning curve is there, but it is just one module, 15-20 minutes, and you're good to go for the rest of the training system.
Is there a stipulated time? How many hours the PGs, postgraduates?
So traditionally, our high-end courses like the SICS or the PIC are a 5-day course where at least you spend 6 hours per day on the simulator. Say a step like capsular rexis or a nucleus dislocation or a nucleotomy on phaco, you would do at least 150-200 attempts in a day. You will continue practicing that separately versus in a continuous mode, so that you can go from first step to the last step as well as you progress onto the training. So yes, there is more emphasis on the time spent by the trainee on the simulator, aided by an instructor who will guide you through the process.
Thank you, sir.
Thank
How
you.
much is the cost for this thing?
So there is a cost to it. In India, it's pretty subsidized, around 25-30,000 for the course, which is 1 week's time.
For the instrument as such, to buy from a medical college
So
point
we
of view?
don't plan to sell it. There is a lease model. So we lease it to you depending on how much, how many number of trainees you can support in a year. So that's the contribution.
Thank you, sir.
Thank you very much.
Do you have any grading system to grade the postgraduate students while using this simulator?
Yes. So there is a subjective and an objective grading system. The simulator has a page called performance parameters where, say for example, your scleral growth should be between so and so. If you do less, your marks go down, the score comes down, and if you get it correct, the score is up. So there is an objective scoring system on the simulator. In addition, there is a subjective. We also use the ICO scoring system to grade them. So we use both of them, ICO Sim Oscar and ICO Oscar, as well as this grading system on the simulator.
Does it reduce the number of cases they do in the wet lab there, on the either animal model, or has from the simulator they are going straight to the human eyes?
From the simulator, they go to the mentored life surgeries with an attendee surgeon with them, which with the study that we did, that those surgeries required pretty less as compared to somebody who did not do simulation-based training.
Does this have the potential to replace the goat eye based wet lab, which has been going on? What
So
do you look
the
at?
idea is to not replace anything that is already there in the training world. The idea is to augment what is available, in the hope that the outcomes are better on the end result of the patient. If it is augmenting something, it's good, but replacing something is not the idea yet.
Thank you.
Cheers. Thank you.